Hello, my name's Kat,
My name's Aggie.
and we're going to present one of two podcasts on chest radiographs. Today we're going to talk about the basic anatomy and basic interpretation.
Okay, there are four basic radio densities that you need to know about when interpreting chest radiographs. Gas is projected as black, fat dark grey, water light grey, and bone or metal is white. The denser the material, the whiter it projects.
So there are two views you need to be aware of. Posterior-anterior view, which is used routinely. Here the X-rays are shot from back to front, and the shortened version of this is known as a PA view. The other is an anterior-posterior view, and this is used in unwell patients, for example, a ventilated patient on ITU. So in this case, the exact opposite occurs, where the X-rays are shot from front to back. Note, however, that the size of the heart cannot be commented on, as the AP view exaggerates the heart size. It's also important to note if the X-ray has been taken with the patient supine or standing, as this will affect the distribution of any pathological air or fluid.
Okay, when presenting a chest radiograph, or indeed interpreting a radiograph, there are several essential bits of information that you need to comment on. First of all is the name of the patient and their date of birth. Then whether it is a PA or AP view. Next, you need to assess the technical quality of the film. If the film is of very poor quality, then it's unlikely to be of clinical use. You have to check the rotation of the film. You do this by looking at the spinous processes and see if they align centrally between the clavicular heads. Also check the inspiratory effort. There should be at least 5 or 7 visible anterior ribs. And finally check the penetration of the film. You should be able to see the vertebral bodies behind the heart.
So I like to start looking at a radiograph from outside in, and this is to spot any obvious abnormalities that you can miss when you just focus on the lung fields, such as an absent humerus or clavicle, obvious fractures or surgical emphysema. I then like to look at the bones, which also helps with assessing the adequacy of the technical aspects of the film, as Aggie has just mentioned. So if we start with the clavicles, the right one is shown in blue on this slide. Both clavicles will be seen clearly on the chest radiograph. And the spinous processes of the thoracic vertebrae should lie midway between the heads of these clavicles. So in this case, they are, which indicates that the film is not rotated. The ribs also play a role in assessing the adequacy of inspiration taken by the patient. So here the first rib on the left is outlined in red. So the rib comes off the vertebral bodies posteriorly, and this is known as the posterior rib. It bends round anteriorly to insert into the costochondral junction, which is known as the anterior rib. So approximately 5 to 7 anterior ribs should be visible above the diaphragm in the mid-clavicular line. So if we count down, 1, 2, 3, 4, 5, 6. There's approximately 6 in the mid-clavicular line that can be seen. So there is actually adequate inspiration on this chest radiograph. When you count down the ribs, also look for any obvious rib fractures. So lastly, we look at the spine, and we can see the spine through the heart, which means that there is adequate penetration. Moving on to the trachea. The large airways contain air, so are less dense and appear blacker. The trachea here is outlined in red, And if we follow it down at the level of the carina, it bifurcates into the right and left main bronchus. Note, is the trachea central? This is very important because if it isn't, we need to think about pathologies such as an effusion, collapse, or in an emergency, a tension pneumothorax.
Next, we look at the lung hilar. The hilar contain the pulmonary veins, arteries, and main bronchi. They also contain lymph nodes. However, these are only visible in an abnormal chest X-ray. We assess for size and density, comparing one side with the other. Hilar enlargement, asymmetry, or change in density may indicate pathologies such as malignancy, TB, or sarcoidosis.
Moving on to the lungs. If you see something really obvious in the lung fields, always start by describing that first. But describe it first in reference to zones rather than lobes in its location. So, for example, right or left, upper, middle, or lower zones. Always compare one side with the other, and always compare any abnormality, if there is any, with the rest of the lung.
Next, assess the pleura and the pleural spaces. The pleura and the pleural spaces are only visible on an abnormal X-ray. Trace around the entire of each lung, checking for thickening or a pneumothorax or effusion. The vascular markings should reach the thoracic wall on each lung. If not, it either indicates a pneumothorax or an effusion.
So the costophrenic angles, you should always be able to draw out nice, sharp costophrenic angles. If you cannot, then this may indicate either the presence of an effusion, where the costophrenic angle is termed as blunted, or hyperinflation, where flattening of the hemidiaphragms occurs.
Now we'll look at the hemidiaphragm. The hemidiaphragm on the right is usually higher than the left due to the positioning of the liver. You should check for any blunting of the diaphragms, as they should be well defined. Check under the right hemidiaphragm for any free air, which may indicate a pneumoperitoneum, and the left diaphragm should be visible behind the heart.
What's that, Aggie?
So there we can see the gastric bubble in the stomach.
So that's not air under the diaphragm?
No, that's normal.
Okay. So moving on to heart size and contours. Remember that the heart size cannot be assessed on an AP film. The heart size is assessed as the cardiothoracic ratio, which is shown in blue arrows on the slide. So the cardiothoracic ratio should be less than 1 to 2. If it isn't, then there's cardiomegaly. The heart contours are outlined in red here, and the left one consists of the left lateral border of the left ventricle. The right heart contour is the right lateral border of the right atrium. So note that the right ventricle, which has been drawn in for you in red just on top of the heart, lies anteriorly and is not visible on the chest radiograph. The left hemidiaphragm should always be visible behind the heart. If it is not, then you should always consider collapse or consolidation in the left lower lobe.
Finally, look at the soft tissues. Check the neck, the thoracic wall, and any breast tissue. Check for asymmetry, increased density, or air in the subcutaneous tissues. This may show up as dark streaks, which would indicate surgical emphysema.
So that's the end of this podcast. Thank you for listening, and we will be with you shortly.
Thank you.